is Diane Birnbaumer. Diane is Associate Residency Director, Program Director at Harbor General Hospital in Los Angeles, which is a UCLA-affiliated county hospital where they're having huge numbers of opportunities to see throughput improvements going on in their facility. No, it's a county hospital. She's been there for a long time. Since you graduated from that place, didn't you? 18 years. Looks way too young to be there 18 years. But in any case, Diane has joined us for today and tomorrow. The session today is about trying to deal with, and you came up with some great ideas. So regarding throughput to make your departments better, faster, more pro-patient, get those patient satisfactions up, make everybody happy.
Mr. Chairman, do we get to make a 1-minute opening statement with regard to this?
Everybody but you. Yeah. No, please.
Yeah,
And listen, it goes a lot better if you, help us
That's
out
right.
here.
The more you talk, the less he talks, so.
yeah, all right.
Here, look at the three of them are stuffing the ballot box right here. Look at this here. They're teaming up here, tag teaming here. Okay. You know, there is a great prize for this,
There is. Are we going to do the standard joke again?
So I'm going to pass out one of these apiece. I think, look at how many suggestions they put down, too.
Check it out.
Need not be present. Look at more. Holy, we have solved all of emergency medicine's problems right here in these papers here. And this
I want to start out. This question is absolutely essential. The more you have a medium to smaller size department, a non-academic department, not residents full-time, that sort of thing. I mean, the academic departments almost by definition tend to be slower for a lot of reasons. But there are things, and by the way, everybody's always got grand system designs. I want to give you 5 quick suggestions of where the real problem is, and you can throw this around as well. Number 1, there are certain doctors, when they come on shift, the nurses start to cry. Why? Because they are sequential testers. If you don't know what the problem is when you walk out of the room, don't start ordering tests. Walk back in the room and re-talk to them, because if you're an experienced doctor, you know what they got 98% of the time, and get to the point. Secondly, when you know they're coming in, get the bed now. I don't care if I've got the labs back. I just said this one's coming in. I go to the desk and say, admit to Dr. So-and-so, and we will deal with that later. But if I wait till the stuff is back, then they got another 45 minutes or an hour fighting about the bed. Third, full workups in the emergency department. There are things you should do, things you shouldn't do, but we're not the answer to every problem in healthcare. And we start to get into a cycle here where we're doing too much and we can't move the meat. The one in the waiting room really might be an emergency, and you can't do everything. Proper preparation of the patient. When I walk in the room, we have a social contract between nursing and medicine. I expect a patient prepared a certain way. I walked in the other night, there's a foreign body in the eye. Patient is sitting at the slit lamp, the anesthetic drops have been put in the eye, my eye tray is sitting there, I sat down, took it out, shook his hand, said goodbye. If I had to physically put him and get the slit lamp in the room and all that other kind of stuff, it would have tripled my time in that room. That's inefficient. And lastly, defining what is doctor work, what is PA work, and what is nursing work. Because I was the U.S. advisor in Singapore at an emergency department where triage was done by a doc. By the way, you talk about a big department. They saw 110,000 visits. They had 2 docs on. And what they were doing is they did the triage. Doc walked in the room, in these little cubicles in front, said, this is what you need, ordered the tests, and then they were finished up by the house officers in the back. And here was the rule. If the patient had anything different than the doc initially put on this little slip, then they had to be run through again. But you know what? Really smart docs could move from bed to bed to bed making decisions and have somebody else finishing up. We have not looked at efficiency in this country yet with regard to medicine. Why? Because we had so damn much money, we just threw it at it instead of asked intelligent questions about who should be doing what. We're going to have to start doing that. Okay, opening statement.
We're done.
You know what?
A lot of
4 or
these are
5 people wrote exactly what you said.
Yeah, I'm sure that's the case.
That when they were in Singapore, that's it.
Yeah, they said,
There's going to be
I was at
probably
Greg's Hospital.
a fair amount of repetition. So once an idea is out there, if you've got it on your papers, then we don't want to do it again because there's a lot of great ideas here. So let's just begin. Diane, you want to go?
Sure. This one, hospital-wide expedited bed cleaning and a new express unit for ED patients. New construction for increasing beds and bedside registration. Actually, the hospital-wide expedited bed cleaning, think about when you check out from here on whatever day you check out. You check out, a beep goes to the housekeeping people who then go to your room, clean your room, get on the phone, plug in a number, a code, and it's done. And the bed is turned over because there's a lot of money coming from that bed. We don't do that in hospitals. Like this kind of thing. Do any of your hospitals do that kind of expedited bed cleaning? You know, the bed control people, bed cleaning people control the hospital. Housekeeping controls the entire flow in the hospital.
Here's something interesting. I would be willing to bet that the housekeeping people, there are more housekeeping people on day shift than on middle and night shift. And middle shift is when most of your beds need to be cleaned, and they cut their staff back then.
Let me tell you something else. We looked at our own system this way. Here's where the problem was. When the nurses decided when to call down to housekeeping to do the bed. So if it was like 3 or 4 hours before the end of their shift, what did they do? They didn't call in the discharge. So we changed so that the transporter who is taking that patient out of the room to send them home has to push a series of buttons on the phone. That notifies housekeeping. Housekeeping then has to have pushed in another series of buttons within an hour and 40 minutes, saying that bed is now online. We cut the floor staff out of this decision because if they could do less work, they did. By the way, do you ever call up from the emergency department and they say, well, we're cleaning the bed? I've got this vision of 2 nurses licking it from end to end. I mean, what the hell are you doing up there? I can clean that bed in 10 minutes. Get going.
Yeah, we found also that there was a lot of nurse sabotage in terms of turning over beds, in terms of patients being discharged to a nursing home, so you needed to call the ambulance. Well, the ambulance wasn't going to be called till noontime, so that they came in at the end of the shift. And all of that stuff really needs to be looked at, because if you go to the floors, you'll find all kinds of ways that there's being sabotage in terms of turning the beds. And although our hospital doesn't have any kind of this phone thing, all of these hotels, the people who they have 15 rooms a day to clean. They clean those 15 rooms. As soon as they're done, they're on the phone, basically lets people know that room's available. So that's clearly, write that down as one. Okay.
All right, here's one of the ones that's interesting is, this has shown up about 4 or 5 of the people, about the idea of fast-track rooms. There is a difference between, if you can have a dedicated fast-track area, the way your department was created, you have a dedicated fast-track area that's separate from the emergency department. That's one thing, but a lot of departments wind up doing is okay, these are going to be our fast-track room or our fast-track area that's nested within the general emergency department. The problem with this, and tell me if this doesn't happen at your place, which is, that works out fine until about 11 o'clock when you're boarding a bunch of patients down there, and all of a sudden they start to borrow fast-track beds, and then by about 1 o'clock in the afternoon, your fast-track beds are just tied up with regular emergency department patients. And then you still have those fast-track patients in the emergency department, in the waiting room, and there's absolutely no place to put them. And that seems to be a recurrent problem, that you basically lose your dedicated fast-track area to general emergency, to more complicated emergency department patients, and you don't get any of the benefit from moving the people through quickly. I'll tell you what we did, and we just built a brand new emergency department after umpteen years of working in a bus station, and we, for the first time, we actually had a resuscitation room. We never had one in the old emergency department. We used to just throw somebody out of a bed and put somebody in there. And we had 2 dedicated, beds that were going to be our fast-track beds in this little area that, we could do seated patients, and they just got gobbled up immediately. The seated area was where people with chest pain were sitting waiting until a bed opened up for them and the others. So what we did is we took and moved the fast-track into the resuscitation room, putting any patient, who had something minor on the stretchers. So you could examine backs, you could suture fingers, do those IND abscesses, doing those kind of things, figuring that if a critically ill patient showed up, this is somebody you could literally throw off the bed and then use it as your resuscitation room. Otherwise, this room basically sat empty 90% of the time. You would throw your bag case would come in, you do your resuscitation. An hour later, you'd move them out of that room into a more central area so the nurses could keep an eye on them, and the room sat empty. So what we did is we basically turned it into a PRN resuscitation room, and otherwise, it's our fast-track area.
The other thing about fast track is that don't let the other people see that you're seeing people out of order. They get infuriated with that. So the idea is that the fast track kind of has to be where the other ER patients don't necessarily get to see what's happening there, because you can envision that they would be a little upset.
Well,
But it's
but
important-
you can get by that. I mean, it's like when you go out and you call in Mrs. Jones, and they go, hey, I've been waiting here for 3 hours. It's like, yeah, well, this lady here's got a vaginal discharge. We need to put her in the GYN room, and that's open now. You make that announcement once in the waiting room, and people don't gripe about you're going to tell them my complaint. You're the one that's got they don't. So they learn quickly to step quiet.
Will the gentleman with the positive gonorrhea test please come to the window?
Yeah.
That's right, yeah. Several people have put this down, it's worth commenting on, and that is adding PAs. I'm doing a lot of work with PAs now. I sit on they have a Society of Emergency Medicine PAs. I sit as an advisor to their board. The day of the PA is dawning.
I think it's dawned.
Yeah, it's dawned. You can meet this way, and a residency which is not training the residents to use PAs is behind the times. See, the great tendency in our training programs is you got a lot of slave labor, you got free labor, you got residents you can use. Yeah. Well, when they get out, they're going to be the only person there. And so they're going to have to know how to use PAs. And I think that since we've gone to PAs, my productivity, my output is huge. It's huge because they can take care of a lot of the details and then present the case, and we can get going.
I think when you use the PAs, you have to pick and choose what you use them for. At our place, we try and keep them predominantly for the fast track patients, so they can move the more minor patients through while you're tied up doing something a little bit more complex. But the problem is, if you're not getting the fast track patients in, the PAs just kind of gravitate over and start taking the more complex things as well. And now you've got both the docs and the PAs taking care of the complex things, and the fast track patients still kind of languish. The other thing that I think the PAs are very good for, and I think there's a big difference, and people argue with this, there's a huge difference between a PA and a nurse practitioner. PAs fit emergency medicine better than nurse practitioners. Nurse practitioners are much more suited to longitudinal care, working in doctors' offices, following patients throughout their hospital stay. Whereas PAs are much more, their differentials only go 1 or 2 items down. They're more procedure-oriented. The other place PAs become very effective is doing lengthy procedures. And IND is not really a lengthy procedure, but in the time it takes me to anesthetize somebody, cut it open, irrigate it, pack it, do those kind of things, I can see 2 chest pain patients. So getting the PAs to do procedural stuff, I think is a big help.
Actually, the PAs are better than when we have the residents do things like large lacerations, because first of all, they have been trained by us to do it a certain way, and I defy you to find a doc who sews any better than my PAs. And so if there's a big laceration that would tie me up in a room for 30 minutes, I can get an awful lot of patients going in 30 minutes. And, and that's where I should be. They should be doing the longer stuff.
We actually have ER techs that suture and save us a huge amount of time. So you don't even have to pay a PA salary for suture.
Right. And I think that's perfectly fine. By the way, I think we're using less and less nurses and more techs, because to take the patient from the waiting room, put him in the room, get them undressed, get their vital signs, get them prepared on this list I told you about as to how the room should be prepared. Let me give you the example. I don't want to get on this soapbox, but back pain.
It's never stopped you before, but go ahead. Yeah.
Back pain is a problem. If I walk into a room where you still have your shoes and socks and pants on, you've now doubled the time I have to be in that room, and that's crap. Okay? It ought to be properly prepared. Me Tarzan, and me Tarzan wants to walk in the room ready to do my work. And this stuff about helping the patient undress and all this kind of stuff, you know what? It slows the whole process down. Get it right.
Although I would say that there is this belief that some hospitals have all RNs. How many of you have mostly RNs in your departments?
Yeah.
Look at the hands.
I feel sorry for you.
The nurses believe that this is, if they had their druthers, this is what they would do. And the doctors believe fundamentally just the opposite. The doctors say, we need hands. We don't need PhDs, we need hands. We need the blankets, the bathrooms, the food, the clothing with the dressing on. And that But the hospital is focused on these FTEs, full-time equivalents, and it doesn't seem to matter to them that this FTE is $40 an hour and this FTE is $15 an hour, and what does it cost to see a patient? So there's all of these, there's this pushback from nursing that says, we don't want techs, we don't want LVNs, we want all RNs because that's what we think the patients should have. And in fact, in the state of California,
Nursing ratios.
we have nursing ratios that are mandated by the state of California in terms of how many nurses are required in your department. We have a 12-bed department. We are required to have 4 RNs, 24 hours a day.
Required.
Yeah.
Required.
I
At
think-
4 o'clock in the morning, I don't need 4 RNs in our department. One
This
is
is
for
the
triage.
government getting in where it shouldn't be, number one. Number two,
It was
they
the nurse
don't.
union that got in there.
Yeah, they don't bring anything to the table to show that that's the way it ought to go. And my only comment is, if you're an all-RN department, who does the work?
But I think, the reality of it is, but a lot of the RNs don't want to do a lot of the stuff, the menial tasks. And then there you get into the problem of, realistically, the ancillary staff should support the physician, but then you really don't want, it is a waste of an RN to have that person doing a lot of the menial stuff, so you really want ancillary people to support the RN. So I think the ideal thing that I've seen is they have the ratio of four patients to 1 nurse, which I think is ludicrous, because at any given time, 3 of those patients are sitting there waiting for their labs to come back. So you really don't need a nurse to take care of them. What you really want is 8 patients to 1 nurse and 3 techs to 1 nurse. So the doc distributes the orders to the RN level and or the tech level, but the RNs can then distribute it down to another level.
In all fairness, it depends on your hospital and what you're seeing. I think the best thing for RNs is to be with critically ill patients who need monitoring, drips controlled, that sort of thing. That's nursing work. Pushing people to X-ray is tech work. Cleaning up wounds is tech work. Setting up the suture set is tech work. And why should I tie up a valuable person doing stuff which is really not worth it?
I've been told by administration that there are assessments that need to be done.
Nursing assessments.
Right.
Yeah, that's the height of science.
That need to be signed by an RN or a height.
You know,
So how do you get away with one nurse signing all this stuff?
that's really one of the pathological ideas that says nursing and physicians are 2 co-equal professions, and that they will both in tandem see cases and make independent assessments of each other, which is really kind of like, that's ridiculous. You know that, I know that. And so the question is who's mandating that an assessment be done by every nurse? Does the Joint Commission mandate that an assessment be done of every nurse? Well, apparently they are, because if you see what they're asking about nutritional status, learning deficits, and all this other crap that we don't, we couldn't care less about in terms of, but there's on our box now, in preparation for the Joint Commission, there is all of these psychosocial ability to learn, they want a nutritional status. I've never heard one of our nurses say, "You're too fat,"
I said that once to one of our nurses.
It's like, what?
Well, the latest thing is your spirituality.
Pardon me?
Yeah,
They have an alteration in feeding.
yeah.
Yeah. And
There
how
you
do
go.
they assess ability to learn? We're going to do a little Rorschach IQ test on you here, kind of thing.
Well, the last JACO thing now is how does your spirituality affect your health care?
Yeah, your spirituality. In fact, do
That's
any
the
of you have
latest,
to do those
seriously.
head circumferences on
That's
kids?
a new box?
That's the new one.
You know
So
what?
Basically, we're driving the car with the emergency brake on because outsiders who think they know how to do our business are telling us how much staff we need to use and what we need to assess. And I'm here for a sprained ankle. I don't need these things done.
Question here.
This head circumference thing drove
Well,
me nuts.
I think it's been replaced.
Yeah.
by,
Yeah, actually.
How do you get away from a better nursing ratio than 1 to 8 when they have to do these assessments according to Jay?
Well, even if they have to do them, the fact is, don't encumber them with having to do things that they don't have to do, which can be done by others. If I had my druthers, and I really don't understand why the CEOs and the nurse vice presidents don't understand this, every nurse should have at least 1 helper. Every nurse should have at least 1 helper. Greg suggested more, but you will not go to any department where there's 1 tech for every nurse, so that tech can get another set of vital signs.
We've got 8 nurses, 1 tech. And the problem is, That works okay if the nurses will do stuff like, the tech's busy, I'll go and irrigate that wound. That's not what happens. It's like wound irrigation, tech job. You know,
EKG, tech job.
yeah.
Yeah. Well, what they've fallen into is sort of useless union mentality. And if you think it's bad some places, I get to be visiting professor a lot of places. I was in New York at one of the major New York City hospitals. There are 5 or 6 people sitting around. There's a patient falling out of bed. And the doc who's with me, taking me around, says to one of them, you know, you want to help get this patient back in bed? And she said, not my job. Doing nothing, not my job. You know what? We're killing ourselves here. We're just killing ourselves.
Next question.
That ratio sounds great, but what happens when, like at our hospital, what will happen is with the bed situation on the floor, we'll have a ton of holes. So the
Right, you're boarding patients.
is handling like, you know, 5,
Yeah, actually, when
That's-
Rick introduced,
yeah.
when Rick introduced
Well-
me this morning, he talked about the problem we have at our hospital. He called our hospital the other day, talked to my boss, and at that point in time, we had 31 people waiting for beds in our ER, 12 critical, 3 on vents. We had a 2-bed functional emergency department, 2
Right.
beds, with 62 people in the waiting room.
But you're absolutely right, but that
What do you do
shouldn't
with
change. The truth of the matter is, when you start boarding patients, your nurse-to-patient ratio should go up, or your patient-to-nurse ratio should go up. On the floor, they take care of 6 to 8 patients per nurse.
Right, well, we did-
In the
one of the
emergency department,
things-
they're saying you have to do 4 to 1. No, as soon as you start boarding patients, it's, okay, you got these 6 patients instead of these 4 patients. They're boarders. You don't need to get the
One of the
ratio.
things that happened at our place to try to help is the nursing ratio, once their ward admits, is the nursing ratio on the floor, and they
Right.
send floor nurses down. They call in floor nurses to watch, and it's working about half the time, so that we have floor nurses come down and do floor nursing work on the people hanging out waiting for beds.
Yeah.
I'll tell you the problem we run into in California, which those of you who have nursing ratios may be dealing with this. If you haven't, you just need to understand there's a national push for nursing ratios. In California, if we get in that 4-bed area, now 1 becomes a critical patient. 1 needs to be intubated. That instantly changes to a 1 to 2, 1 nurse per 2 patient ratio. Well, now what do? That nurse was assigned for 4. Now we've changed the ratio requirement, and you just scramble to get other people available to take care of them. It's become an enormous
The ratio,
mess.
and if the nurse needs to go to the bathroom, my God, they have to
Or take
call.
a lunch break.
Yeah,
Here's the real problem. It becomes fodder for plaintiffs' attorneys, and I've done California cases where the question was, oh, so now you're doing this. Doctor, did you realize that in your department you should have called a disaster this or that because the nursing ratio had shifted? And it says right here, this is how many nurses you needed, like the nurse was magically going to make the patient better.
but the problem with that though is then that the nurse that's taking care of the 2 ICU holds and her other however many patients is the nurse that needs to put her finger on the Pyxis to just get me the lidocaine so that
Right.
so the quick cut and get them out.
Yeah.
I'm the only doctor
Yeah,
at night with no PA.
We still have lidocaine in the drawer.
yeah.
You know, we still have it.
You're breaking the law.
We have it in the drawer.
You don't have lidocaine anymore, do you?
Yeah, we have it in the drawer, and we can just open the drawer. And when the Joint Commission comes around, we lock the drawer.
Yeah, everybody does that.
That's what we do.
I have a question related to that issue that anyone here maybe have any experience admitting people to the hallway beds
Oh, yeah.
upstairs, because we're trying to develop one of my hospitals, and a lot of people are so horrified, like we're sending them to the third world country.
Maybe you are.
It's a hallway bed upstairs.
Yeah.
Somehow it's so foreign here.
Listen, I'm from Michigan. We would be a third world country if we had better weather.
Peter Vecellio is making a reputation for himself as going around the country talking about the success that they've had supposedly at Stony Brook in New York regarding the movement of patients to halls, because their halls are actually nicer than our halls. They're
Yeah.
wider, you know, and they don't have any call buttons. We don't have any call buttons. So the halls are the halls of the halls. And that once you threaten the floor that they're going to be a patient in your hall, they will find that bed. They will call that ambulance. They will get that bed cleaned. They'll do anything to prevent that. So it serves as a threat to motivate them to find a bed. And if you need to put them in the hall, and it sounds so logical. Why would we contain all of this to the emergency department where it's just utter chaos, and we could disseminate it through the hospital? So he makes a very good plea, but our nice nursing vice president, she responded when we suggested this. Her quote was, "over my dead body." Let's contain this nuclear disaster to the emergency department, and let's not contaminate the hospital with this opportunity.
By the way, we could run much more efficiently, and what you really see, when we had this problem, went to the chief of staff, said, look, we need a bed Nazi. We need a guy who walks around and says, this one's ready to go. The surgeons are never a problem. If you don't have a dehiscing wound, they want you out of there. Surgeons don't like people in hospitals unless they're cutting on them. They don't want them there. It's the internal medicine people who say, well, can't grandma stay 2 more days with her congestive heart failure? The answer is she's more likely to throw a PE, catch another disease, fall out of bed. You need to get them out.
Do any of you have someone who's in charge of the patient flow?
Well, there's 2 types of Nazis. There's the doctor Nazi who's looking at whether they need to stay, and then there's, for our purposes, the more important bed Nazi is the nurse who goes around and says, you guys are hiding 2 beds. You know, this guy's going home in an hour, get him up and out of bed, and that's the one who's really important.
And by the way, there's lots of things you can do. We have a discharge area. Let's say, well, my family can't come to pick me up till 7 o'clock tonight. Fine, we move you down to the lounge, but we want the bed. This isn't Howard Johnson's. You didn't buy it for 24 hours. We want the bed. And I think that this idea that we discharge people at 5 or 6 o'clock in the afternoon because doctors have come from their offices and now they're writing the stuff, that's all gone now. That's all old
Do any of
thinking.
you have a holding area for discharged patients who were in the hospital to wait for their families? We actually did this for a while as well, and it did help us a lot. The problem is we lost our nursing item, because you need to have someone there to make sure that they're living, breathing, walking, talking while they're still in the hospital.
No, it's interesting. St. Barnabas did it, and
That's exactly right.
exactly what happened is
They don't want to do that.
it functionally worked very well, but the people griped about it. So then what they did was, St. Barnabas is actually a very smart place up over in New Jersey. What they did was they just got the Four Seasons to come in and spiff up the waiting area. So now they all have Barco loungers and, well, you know, plants in there. They all had their own little TV and stuff, and made it like a nice little, you know, lounge. And then all of a sudden the complaints went away. So you can do it. The idea is you need to get them out of the bed. But if you get them out of the bed to a nicer area, it's okay. If you get them out of the bed to what most people do, they find an empty room and just stick them in there, they're not going to be happy.
Yeah, we put a fish tank in ours. The problem was then we had patients fishing.
This is a session on how to improve the throughput. This person wrote that computerized medical records starts next week. That's probably going to be but he also did acknowledge that was likely to be inefficient for a significant period of time. Computerization of medical records is, you know, it's not going to, I know of no doctor in the emergency department that says, I've got to get this record computerized. You know, I've got to basically be able to do this. Dictation is no fun anymore, kind of thing.
Well, no, there are efficiencies. There are efficiencies to an electronic record. You know, and especially physician order entry, there are some efficiencies too. The problem is, what you don't want is somebody standing in front of a computer screen clicking a mouse to document the patient encounter. That's where you lose all your efficiencies.
By the way, our complaints, you talk about Press Ganey scores. We had one place where the day after the computer system went in, there are the docs staring at a screen, not looking at the patients.
Yep.
The nurses are out around their cubicles, again, filling out the form, not looking at the patients. And if you think that the patients were happier with this, you're just plain wrong. They're not. The other thing is, I actually have some young partners who have not actually looked at the patient except when the moment they walk in the room, they're staring at this screen.
Yeah, I think that's the worst thing in the world is to bring those walkabouts or laptops or whatever into the patient room, because you really convey a real bad connotation of what you're there for.
Image.
It's a bad image. The other thing is, though, there are some advantages to it, but by and large, I think that the best model is you can have the computerized record, because the nice thing about it is nobody can tell who entered the data. So all you have to do is sign it at the end, and it looks like you're the one who did the whole record, versus having to write attestation notes and everything else if somebody else does it. But the model that a couple places have gone to, and we're working towards, hopefully within about 6 months we might get, is these ideas of what are called Sims. I don't know where the name came out. I guess it's from the computer game Sims. What basically this person does is When you walk into the room, they walk into the room with you. And they're not exactly a scribe, but you kind of have your conversation, then you kind of summarize it, turn to them and say, okay, this is what we found in the physical exam, this is, what's going on. They then do all the data entry for you. They also, you say to them, okay, and we're going to send Mr. Jones home on these 3 medicines. They enter the data in for the script writer, so the prescriptions are written for you, the discharge instructions are written for you. They're basically like a personal assistant who takes care of all the paperwork, and you just move from room to room to room. The people I know who have initiated those kind of things, and it is personnel dependent, say they, without breaking a sweat, can see 5, 6, 8 patients an hour without breaking a sweat when they're working with Sims. I'm going nuts trying to see 2 an hour, handwriting everything, and we don't have a computerized record, everything down. Because you have to document everything. I have to write my orders, give my orders to somebody else. They do like the computer order entry because they can cluster stuff. So with 1 click, they can do everything.
It's kind of sad to talk about hiring a person to push the buttons that you were intended to push.
But yeah, but
It's kind of like, but I also do, we call them scribes, but it's not a good term because
they're more than scribes, yeah.
Here's
Your x-rays are back, doc, here they are for you.
Yeah, and our doctors, some of our doctors just swear by them and some swear at them, but they definitely create the opportunity for you to move faster. When you're suturing, they can go ahead and get some family history, social history, all this other stuff
Right.
For the level 5 exam on the next patient so that you can go in there and be prepared to see them and you're not starting cold. And they definitely facilitate doctor work. Question of who pays for them? Our physician group pays for these people to facilitate our doctors. We have a lot of old doctors, and their adrenal glands are like little raisins now. They've been working in emergency medicine so long that they're little raisins. So it's anything that will make their life less miserable, that will facilitate patient care, that will make them happier, that will make things just go smoother. It's worth $15 an hour for us to pay for those people. So some people say, to draw the line in the sand and say, well, a hospital should pay for this. I know a physician where the hospital and even the physician group does not have the use of these people. This doctor, when she comes to work, her assistant comes to work.
Right.
Her assistant works the identical shifts that she works. They meet together. She pays this woman who assists her, and the 2 of them work when they're on the shift. And when the shift's over, they both go home.
By the way, this is an economic question. If you're paid productivity, on DRG.
That's true.
Yeah, this is strictly a financial analysis. If you're slow as a typist, and I am.
Doctors, you've got the most expensive data entry person.
Right,
in the field.
that's the whole key.
Exactly right.
That's the whole key.
By the way, we have sort of a rule that as we're taking guys out of the residency who are starting with us, what we know is first day out, they will take a chart off the rack. Let's say there's 10 charts waiting to be seen when they come on. Within about a year, they understand you pick up 5 charts, you go in and get people going, and it's a rhythm thing, which in most training programs, we don't have a specified increase in output for each year. What does a first year see, a second year, a third year kind of thing? And it takes us about a year to 2 years to get somebody into the rhythm of moving patients.
But you're absolutely right, because the rhythm also includes, when I walk in, I can get, in the first hour, you can get 10 people started.
Right.
But then as the results start to come back, there's a certain rhythm to, I ordered an x-ray, I know it's going to take 15 minutes to get my x-ray back, those kind of things. There is a certain cadence to how you see patients.
Now, a lot of these papers talk about getting a lot done in triage by standing orders and auto-ACL rules and getting the things ordered there.
Actually, there's an interesting sort of comeback to that. This is recently we revamped our entire ED process in an 80,000 patient per year ED. The goal was to have the doc to the patient as soon as possible. Step 1 is quick registration. Only ID or driver's license. Takes 2 minutes to get into the system and generate a chart.
Yeah,
Step 2 is to screen the patient quickly at triage, forgetting all those advanced nursing protocols, x-rays, etc. Then patient immediately to a bed in less than 10 minutes after arrival to see a doc. The doc in the geographic area is responsible, and once the patient's in a room, the doc sees the patient in less than 10 minutes. If the patient is a quick discharge, they get their full registration done after they've been evaluated by the doc, which sounds pretty cool, actually. If they're admitted, then their full registration's done at bedside. It says the wait times, length of stay were all down, the wait times were down drastically, length of stay down drastically, and satisfaction survey up across the board.
This is,
Yep, that's well documented. All those points they in are very well
that's
documented.
what we do at our hospital in that we have no triage. The only time to have triage is when all the beds are full. Now, if all the beds are full all the time in your place, you get bigger problems. But if you are working at a community hospital, which is trying to compete with the hospital down the street in terms of patient satisfaction, you want to take their patients away from them and have them come to your department, which is exactly what we want to do, then there's no triage, there's nobody asking all those ridiculous questions. That person is brought back into a bed. Our door-to-doctor times are 30 minutes or less. 80% of the cases are 30 minutes or less. The door-to-doctor times are tracked on every doctor so that we know when the chart, the time of the initial assessment by doctor, they put it there. If they don't put that time there, we also know the doctors who are not putting that time there. We know the doctor's not playing the game. We plot all of these things, and we have a meeting every 2 weeks with administration showing them our door-to-doctor times. If you show the doctors the door-to-doctor time, in terms of patient satisfaction, you will not make a patient more satisfied than getting them to the provider quickly. And the more steps that you put in the way of that, the more problems you have. Most ERs are going to have 5 people see the person before the doctor, or 4 people. They're going to see they're going to go to the triage nurse.
They go to greeter.
Once it's ascertained that you're going to live, then you go to the registration window, and they get all the registration except they don't ask you how you're going to pay. Then you sit down in the waiting room. Then a tech is going to bring you back into the department when it's your turn to be seen, and another nurse is going to see you and ask the same triage questions that were asked by the first nurse, and the doctor is going to be the first person to see you. You'll never get a door-to-doctor time of 30 minutes routinely if you do that. You just have to abandon.
There are some inherent, first of all, on all those points, there's some real good things. The one inherent problem is when you do discharge registration, is people just walk out.
Yeah, we don't do discharge registration. We do bedside registration on every.
Yeah.
Yeah, we ask too many questions. There's stuff about your religious preference. They'd asked a guy one time, he said, well, why do they ask me about my religious preference? Well, and I said, well, that's sort of one of the things you do. He says, my preference is not to need one, so do it right.
Yeah.
And I thought that was the right comeback.
I was the one that wrote that. And what we do, as far as your point, as far as discharges and people walking out, in order to empty that bed out, get them out to exit registration, we do not hand them any of their discharge instructions or their prescriptions. They get handed to them after they've fully registered.
Good.
Yeah.
Good
But-
idea.
but
That's a
point-
great. What hospital are you at?
Baltimore Washington Medical Center in Maryland.
Yeah. My point is still that cut down the number of questions you ask, too. People are much more likely to give you correct information if it's a limited number of questions. All the survey people know that. If you have a survey that goes on for a half hour, you get tired and just you forget it. If you got 5 questions, they're much more likely to get it right. And we don't need most of that information. A lot of this will be taken up.
It's the one-size-fits-all. You're coming into the hospital for a coronary bypass or an ankle sprain, you'll be asked the same questions. It doesn't make any sense. I'm here for a tetanus shot. They still want to know your religious preference kind of thing, and is your husband beating you up?
It's true, yeah.
You gotta answer that too.
Yeah, I love that one.
What happens in a situation like that? I guess I should pose this question to you, unless you have several docs on at one time. If you get in one room a trauma patient, in the other room a CFR that's acute that needs to be intubated, does that then back up your entire system? Because how do you get then those patients registered who are not coming through the ambulance bay, seen by a doc within that time? Because oftentimes you may be the only doctor
Yeah,
on.
but that's an ebb and flow issue. I mean,
Our goal is,
yeah,
80%
you-
of the people get seen within 30 minutes. So
Right.
It's not,
It's not 100%.
Because you're going to have just situations that you mentioned. But if we can get 80% of the people a door-to-doctor time, not door-to-triage, not door-to-doctor.
I do think this idea of very quick registration, get an ID and a name and birth
Yeah.
date, and generate a chart. That way your job is much quicker. It's so frustrating to have your stuff done and no chart to do it on.
We went to, when we moved to the new place, we went to quote-unquote bedside registration. So they still get triage and they get brought back to a room. And on last Sunday I worked, the docs had lapped the registrars by 10 patients. So we were 10 patients ahead of them, with discharge instructions and everything written on some of the patients. Yeah, and they're still waiting for the registration. And unfortunately, our registrars grew up in the era of they just sat there and everything came to them. Now they're being asked to get up and go to the bedside.
Do I have to get off my fat ass and go in and talk to the patient?
Well,
Oh, my God.
No, but the difference is there is a, when you're working in the back, there's a certain, you pick up your pace as it gets busier. They don't kind of get that. And they do have a very, the computer works at a certain speed, and that's what they work at. It's da-dum, kind of. I mean, if you were to have a theme song, that would be it for them, and they just kind of plod along.
I
And
put thyroid in the coffee maker.
yeah, really, but it is just their, I guess, cultural, thing. And it's interesting because we hired a couple new ones, and we hired this young guy who's, as a part-time job, and this guy would out-register them 5 to 1. He'd look and say, okay, those 3 people have to be done. Boom, boom, boom. We do those 3, come back and bring the charts in. Yeah. They kneecapped him. That was it.
So, go ahead.
One of the issues with that is you have to look at how your hospital evaluates registrants, because they probably evaluate them more on, they fill in all the.
Correct.
And
Correct.
nobody cares about.
Did they make a mistake on the insurance number? You're absolutely right. So the people, they're working for finance who gives them reports based on, how many digits they got right on the insurance form versus us who are looking at them like, just give me a chart. I don't care, just handwrite the chart. Just give me something to put orders in
One
on.
of the things we did is our charts did not require any registration. You just pull them out. We don't use T-charts, but I mean, you could use something like that. We just get the chart and start writing. And the fact of the matter is that you don't have to have a chart generated by the registration process, which is a rock around your neck.
Let me tell you, there are occasional hospitals out there that are that are far thinking. I was just hired to be the coordinator for a hospital which is going to build a new emergency department. I said, I'll work with you, but we're going to have a 2-day retreat, and X-ray's got to be there, lab's got to be there, admitting's got to be there, the chief of staff's got to be there. And we sat down and started to look at each one of these. There's no one solution to efficiency. You have to look at a lot of questions. And one thing the hospital came up with is they had a fairly circumscribed geographic area. Everybody who's been in the emergency department in the last 3 years is going to get sent a registration card with all that information on it. So when they come in, again, and believe me, in smaller towns, they're going to come in again. It's the only hospital in town. All they got to do is shove the card into the machine, hand the patient the piece of paper and say, anything changed on this? And when they actually did some of these studies looking this down, it'll cut the time of the registration people less than in half. I mean, this is the kind of thinking you need.
Honestly, there's lots of time. The time where there are lots of time is when you're in the bed waiting for something to happen. And I got my ice bag. I'm waiting for X-ray. Now you can talk to me all you want.
Yeah.
You can ask for my co-pays then. There's lots of time to do the registration. Just don't make it an encumbrance to be able to see the patients. So what there appears to be here is there's a dichotomy. Some people want to amp up triage and have all of these standing orders in triage and those kinds of things. And some people want to dismantle triage and get them right back into the department.
Yeah, here's our problem with too many orders at triage. It's better they get back to me quickly because actually we run then into over-ordering. The nurses invariably want to order both a foot and an ankle, where if I actually looked at this, I only need one X-ray, or I need no X-ray. They want to get a blood study going on everybody, and I get a blood study going on almost nobody.
Yeah, but the problem is those nurses have to work across multiple docs, where you're a diagnostic nihilist, and other people may be, I like to circle the whole right side of the chart, every test I want on every patient,
Right.
So that becomes difficult.
That's why it's better, I think, to move them as quickly to seeing us. By the way, somebody mentioned the Press-Ganey scores. Press-Ganey is almost like a magic word now in the country to administrators. It is the thinnest statistically based thing in the country, and you can outwit that anytime you want by teaching the test.
Yeah.
For example, we taught the nurses to say as they're pulling the curtain, I'm closing the curtain for your privacy. Because one of the questions on Press-Ganey is, did they pay attention to your privacy? As soon as we did that, the Press-Ganey scores went. In fact, there are 5 or 6 questions there. We know the questions. We've taught people the answers, and it improved the Press-Ganey score. Did it improve the care?
If you have, there are
No.
other systems besides Press-Ganey.
Yeah.
I have a friend who works in an ER where they use a different system, and they actually, to make sure they get an adequate patient sampling, they will call if there aren't enough responses. But when they call, they start the phone call with, "Hi, this is so-and-so from X hospital. We would just like to question you about how you felt about your excellent care at our facility." And it starts it off.
Trained by a chiropractor.
Yeah.
But it's interesting, when I went to buy my car, get my car, I went to this, it's a Saturn, and they are really big on satisfaction. And from the minute you walked in there, you could tell they were gaming you towards, at the end when you filled out your form, and when they, so a couple weeks later, they send me the form, and the guy from Saturn calls me and he says, listen, you're going to get a form in the mail, I just want to, kind of let you know it's going to be coming, and it's real important to us. And what would it take for you to give me good responses? How about a free oil change? So these guys are like preempting it, even to the point where I will bribe you for a good answer.
Well,
Which I thought was pretty cool, because I did get the oil change. Yeah.
we'll give any employee, the physicians will give any employee whose name is put on a satisfaction form in a positive way, $25. The physicians will incentivize the employees $25 if you get your name mentioned on any.
Yeah, we get WOW chips, which you can take to the cafeteria and turn into like a soda or something.
Yeah, our administration
Smart enough to do this, so the doctors are going to do it. Because we're painted with the
Well,
same
here's the thing you should know. A large number of the CEOs have bonuses based on Press Ganey scores. They have to be such and such. And the problem in New Jersey is it's not your score. They didn't make it an absolute, your score should be X. You have to be in such and such a percentile. Well, you know what? After everybody learns how to do the game the system, now everybody's in like that, in a 2% range of their answers, but yet the percentile is spread over 100%. So now it's almost impossible to stay in the 90th percentile, because that means that if one person says they weren't happy, all of a sudden you're down in the 10th percentile because everybody's gamed the system so effectively.
You don't actually want to look at that statistical base, by the way, because very small differences can make huge, this is
But they don't care.
This is not good science.
Okay, you didn't get to be the CEO because you understood statistical analysis.
I understand that.
Here's one that looks at the back end of it, which is kind of interesting. We did something similar to this, which was, it says, ER doc writes holding orders that expire in less than 24 hours. There's always been this concept that, my God, if once they leave the ER, it's somebody else's responsibility. Don't write admitting orders. There's a difference between holding orders and admitting orders. Holding orders are, you have a bed upstairs. I can get you up to that bed and you'll be more comfortable. Here's a couple things like, this is how often you get your vital signs taken. This is, what you're allowed to eat. This is whether you're allowed out of bed or you have to stay in bed. We want a cardiac monitor on you. If you get chest pain, these 3 things are going to be done to you, and they're going to call your doc right away. It gets them out of the emergency department. Having somebody languish down there because they don't have their orders written is counterproductive to us. I think, there's a difference. You don't want to write admitting orders, because admitting orders means you figured out their Synthroid dose and you're writing that. But holding orders are just the menial things that get them physically up into another bed. And it's worked out tremendously when we do get a bed for somebody.
Here's one that really I've not seen before. It's called the Gold Pass for people sent over by their private doctors for evaluation. You don't want Well, I guess it didn't go well with the first row. The Gold Pass is given to patients referred from PCP offices for evaluation and admission. These patients go to the front of the line. Now, I'm just reading. I'm just a conduit here.
Yeah.
So I guess you don't have for the Gold Pass idea here.
Yeah.
This whole town runs on that.
Yeah.
It annoys you the most.
Expectation that they're gonna be seen first, which is even more annoying because then they're pissed at you because
Their expectation is they're going to be seen. Didn't my doctor call over and say, I got this
Yeah.
fibromyalgia attack?
my doctor said I would be seen and I wasn't.
Oh, well, it's even better when they show up and they say, my doctor said I was to be taken right back, and it's like, your doctor didn't call. Oh, yes, he did. You must have lost it. It's like, no, your doctor never calls, and in fact, he sent you here because he's annoyed with you. Yep. That's.
Although, the medical staff is your customer. And to the extent that you can make the medical staff happy by accommodating them in some way. Now, I'm not just saying that this is, but this acknowledges that they're patients, so they're trusting you. You would like them to have them come to the ER because we can do this work up quickly, we can get everything done, we'll accelerate this for you, yes sir, yes sir, yes sir kind of thing. So you make a good impression on your medical staff. I think it's
But if you have the resources, absolutely, it makes sense. I can get a CHF patient tuned up in an hour from the time they hit the emergency department versus 6 hours when they go as a direct admission. The problem is, if you don't have the resources, you're already boarding 13 people, and here comes the 14th one in. And the other thing is, why did doc send it to the ER? Well, they sent it for one of two reasons. One is they did want you to accelerate the care, or they tried to admit them in admission, said there's no beds.
Right.
In which
It was
case,
confused.
Or it's the end of
yeah,
office hours.
Yeah.
yeah.
Or they're confused about the diagnosis, and quite frankly, in their offices, they don't have the
And
test
that's
facilities we do.
legit.
That's perfectly fine. Yeah, by the way, you can just tell, English is not a tonal language like the Asian languages. That's a tonal language, but it is tonal. You walk in and you hear the nurses when somebody says, "My doctor sent me and he's going to meet me here." Now, there's some ways you can answer it. Some people go, "Oh, sure," and another group go, "Sure." And see, it's the same word.
Yeah.
But now you've just pissed them off. And so what I do is I walk in and say, "Oh, Dr. So-and-so's coming. That's great. He worked with me very closely. I'm going to get you going." Now, I know there's no way in hell he's coming in. Okay? It isn't going to happen. But it's how you spin that to the patient. If you're part of the team, great. If you're now angry that the guy sent the person over and they sense that anger, they are going to convey that to the doc.
But that's a passive way to get back at the doc. It's like, I'm going to get even with you. Yeah.
You never fight fire with
Yeah.
fire. Right.
So another one, again, any others that haven't been covered, I'd like to mention this one, incentivize physicians so that they work harder, they get paid more.
Yeah.
And there's more and more groups that are trying to come up with fair systems to incentivize their physicians so that they can do this. It's not necessarily easy, but the fact of the matter is that there are some very primitive ways. You can just measure how many RVUs you generated compared to all the other RVUs generated.
Right.
But we're moving through that in our group, but you know, the doctors say, well, you know, this doctor works all nights. His opportunity to see patients is less. This doctor
Right.
gets
You
to
have
work
to
with
make-
the residents. This doctor gets to work with the PAs. This doctor has the scribe, so that some doctors have workers that will facilitate the work and others don't, because when they work, they have all kinds of different hours. But it will probably come down to what percentage of the RVUs did you generate last month?
Yeah, it's more than that. I mean, a lot of the systems that I've advised and worked for, they do come up with other things. For example, they give you got to show up at the monthly meeting. If you haven't, points taken away. If you're on hospital committees and you're not going to your committees, points taken away. If you're not, if you are the president of state ASAP, you get points into the system. So it's more than just seeing patients. I think our work is larger than that, and that ought to be recognized somewhere in the financial system.
You touched on something, and I didn't see it mentioned in any of these things. I don't know what those two are doing over here. Yeah.
That's a good one.
All right, well, let me do this, and then we'll do that, because we could end with that. And that is the importance of getting involved and seeing the medical staff outside of the boundaries of the emergency department. When you get your tail on some committees and you go to different meetings and see these people, the way they treat you changes. If you're on a committee with a doc, number one, you bullshit with them before the committee meeting starts. You work with them, maybe you support some contention of theirs in the committee meeting. You walk out of the meeting with them, that makes a difference. You have a different relationship with them. Now when you need support or you need them to change a behavior in either their department or even within the other members of their group, it is much easier to do when they see you outside of the realm of just somebody who calls them up when they have an admission to dump on you. All right, go ahead.
Well, I think this is probably the winner.
Without question.
This suggestion is probably the winner. They would like to have a vending machine in the waiting room that would dispense notes for release to work.
You know how like the coffee machine where you put
Yeah.
a little bit of cream and a lot
Yeah.
of extra sugar? I'd like 2 weeks off,
Yeah.
no heavy lifting.
By the way, the first textbook in the history of the world of medicine was written in Egypt about 2700 BC. The last case presented in the book is low back pain from working on the pyramids. There is in that book perfectly well translated by a guy by the name of James Preston. Perfectly good work. It says, basically it says, can Sabu have the day off from heavy lifting at the pyramid? Then there was an area they couldn't understand what it was. And you know what it was? Sabu had changed the date on the worksheet, 2700 BC. So this is a long-standing problem.
All right, so those are the solutions to the world's problems.
Yeah.
Will you write them down, kind of thing? You know?
By the way, Vic Jordan, this is basically a textbook on what to do. Nice job writing this up. I think we hit some of your. I'm not sure who you are, but good job here.
One of my beliefs is that if the CEOs, not just on patient satisfaction, because ER patient satisfaction is small compared to the whole hospital, if the CEOs had their bonuses driven by the performance measures in the ER related to throughput, those kinds of things, this problem would be fixed easily. This is a top-down problem, and they just choose not to fix it.
Yeah, you can rail all you want against something the nurses are doing in the hospital. Unless the CEO tells them they have to change, they're not going to.
That 31 boarding patient day, we called the hospital, actually, the medical director and the CEO, and we were basically told, and?
Yeah.
I was like,
What's your point?
hello?
And
You want
just
to
so,
walk down here?
yeah, just so you understand, in a lot of places, if they can, their goal is to tie up the emergency department because you're admitting pneumonia patients, dwindles patients, those kind of things, infected decubiti, that are tying up the beds they want to use for their elective cath patients and those types, their quote-unquote paying patients. So to their mind, the more they can screw up the emergency department, the happier they are. And they are insulated from the emergency department. Someone complains, it's the emergency department's problem. Even though everybody in this room knows the solution lies with them, they can easily just say, you know what, you guys just aren't doing a good job down there. You know, I don't want to hear any more complaints about it. And you're basically powerless to stop it until people recognize that the solution lies with them. They're happy as can be to keep you bottled up.
So
We're done?
how are we going to determine the winner?
Throw it and see which one goes the furthest.
Just
Are we
pick
going
one.
to do it on merit? No.
No,
Never.
never.
Since when would we do that?
Yeah.
Well, I told them
RVUs?
they were going
No.
to do it on merit, so I kind of baited them. So Diane, you're our newest member. You're the
Yep.
blossom among the
Merit
thorns.
is-
Yeah.
While she's doing that, the blue is for tomorrow. The blue is also going to get you a EMA or one of our MPrep for LLSAs. We want you to put down a diagnostic or therapeutic controversy that you would like us to collectively discuss with all of the people in the room. A diagnostic or therapeutic controversy. So when you can fill them
Yeah,
out.
what do you do with,
You know, exactly.
yeah.
Clearance exams for psych patients, all that, those kinds of things. Write one of those down, and we'll go over them tomorrow as well. If you can give us back by tomorrow, that would be great. Just any time doesn't matter.
Yeah,
Who's the winner?
Diane picked, this was random, Lawrence Cashman. Congratulations.
There you go.
Tell him what he's won.